Good afternoon. My name is Liza Osipenko. Welcome to Consilium Scientific. Some people joined an hour early today because in the US, the clocks have not been changed yet. So hopefully people will rejoin just at the right time. So today we're welcoming Dr. Giovanni Fava, who is currently based in Italy. But in his career, he worked across the Atlantic at the University of Bologna in Italy and State University of New York at Buffalo. And Giovanni just published a new book, which came out in September. The link is in the description, and also you can find it in Amazon. And welcome, Giovanni. So we look forward to hearing your talk on the role of clinical judgment in psychiatry.
Thank you very much. I'm glad to have this opportunity. Let's first of all let me disclose my conflict of interest, which is essentially this book, which I've written on clinical judgment, for which I'm going to receive royalties. Uh, Mm, You see, there is a big paradox. In their everyday practice, psychiatrists use observation, description, classification, test explanatory hypotheses, and formulate clinical decisions. Um, when we evaluate whether a patient needs admission to the hospital, when we have to decide whether the patient needs treatment, and in case what type, the psychiatrist, as any other clinician, uses nothing more than clinical judgment. Uh, However, the paradox is that there is little consideration to clinical judgment. In the medical literature, in psychiatry, this is the topic, my topic today, but in the entire medical literature. And clinical judgment is often perceived as an art that is going to be replaced by hard science, growing technology, artificial intelligence, and so on. We try to show that this is not really the case. Uh, you see, when I started my clinical career, I had the feeling that improvement in my performance was a function of upgrading my clinical judgment. So I had to capture how senior colleagues and nurses came to certain conclusions. And I was also looking for knowledge that could help me dealing with complex and difficult clinical challenges. Uh, in those days, there was only one book in the medical literature uh, about clinical judgment, which was written by Alvin Feinstein, the father of modern clinical epidemiology, professor at Yale, published in 67. And you know what the paradox is? It's still the only book on the topic if we consider the medical field altogether. And Feinstein defined clinical judgment as a type of reasoning for making decisions about prognosis and therapy of patients. Uh, the background of clinical judgment is clinical experience. So there was this book, and a few years ago I started wondering whether it was time for me to write something on clinical judgment. Of course, I didn't feel like writing something about internal medicine, and I decided to select my focus to psychiatry, the specialty that I took. And I must, I must say that I, uh, uh, I realize why books on clinical judgments were missing, because it was damn difficult to write this book. Uh, it took me it took me really a lot of effort. But the conclusions of this book may pertain to any other medical specialty. What I did try is an updated definition of clinical judgment as an interactive process that consists of data collection, interpretation, and reasoning, and making decisions. These three phases. Clinical judgment goes beyond diagnostic reasoning, integrating patient cues and ranking them in their clinical impact according to specific priorities. Let's have a look at these three different phases because we'll try to describe them in this presentation. The first is gathering information. The second is clinical reasoning, interpretation. And the third is making decisions. But these three phases interact with each other. For instance, you collect some information, you start with an interpretation that you have some doubts, you go back, you try to collect some more information. So it's really an interactive process. Um, let's have a look at the phases one after the other. I'll try to give some ideas about it. Gather information. Uh, the basic method for data collection in medicine and psychiatry is clinical interviewing. It's it's getting is interviewing the patient, which is an art, getting the information from the patient, and observation, physical examination, laboratory and imaging methods, of course, may provide supplementary information. For instance, there are many data collected in primary care that suggest that about 60% of diagnoses are based on clinical history, another 20% on physical examination, and the remaining 20% on laboratory and imaging methods. But clinical interviewing takes time, and in healthcare, this is often considered a waste of time, whereas it's the best investment we can have. In psychiatry, we have a specific problem, the fact that comorbidity in what is the Bible of psychiatry, which is called the DSM, the Diagnostic Statistical Method Manual of Mental Disorder, is comorbidity is confined to psychiatric and medical diagnosis. While there are several clinical aspects that would qualify for comorbidity and have primary importance for clinical judgment. So, to get clinical judgment, we need to expand the range of issues that are restricted in psychiatric practice. Again, we go back to Alban Feinstein. In 82, he introduced the term clinimetrics as a domain concerned with the measurement of clinical issues that do not find room in the taxonomy that we generally use. These are only few examples: types, severity, and sequence of symptoms, rate of progression in illness, severity of comorbidity, psychosocial issues, problems of functional capacities, reasons for medical decisions. So we need to take into consideration not only symptoms as we are led to concentrate on, but also other variables. And we'll describe these variables in a moment, which is allostatic load, health attitudes, euthymia, psychological well-being, personality, medical vulnerabilities, and iatrogenic comorbidity. Uh, that may sound complex, but let's consider a case, and we see that it's not that complex. And we're talking about a 64-year-old Italian woman um, who has a major depressive disorder of 8-month duration, did not respond to sertraline, an SSRI, prescribed by a primary care physician, up to 100 milligram per day. She also complains of persisting nausea. She wonders whether it can be caused by sertraline. But the doctor said, absolutely no, no. He prescribes several anti-nausea drugs with little success, many times with side effects of antidepressants. Ordinary drugs don't work. So what he does is prescribing what he believes to be a stronger antidepressant, which is venlafaxine, first 75, then 150. But again, little effect on mood and worsening of nausea. Again, the patient say, but it's not, I never suffered from nausea before. Isn't this medication causing the nausea? And the doctor said, no, absolutely not. And refers the patient to us. Let me make here just an observation about the spectacular achievements of propaganda. Here, it's a list, partial list of the side effects that newer generation antidepressant medications may cause. And one of the most common is actually nausea, vomiting, gastric burning, weight gain, cardiovascular problems, osteoporosis and liability to fractures, bleeding. So quite a lot of side effects, but nausea is really very, very common. But these are simply the data about depression, how it was treated, and did not respond to 2 consecutive trials with medication. So I try to look into the history of this patient. Yes, she has a major depressive disorder, but she didn't have any previous episode, and she reports a 5 kilogram weight loss. And then I try to look, explore a life, and I had the idea that she managed a difficult situation about growing 2 children, being very busy in a bakery, helping her husband. And the weren't the life setting is very, very important. She did not report particular problems until about 2 years ago, when she and her husband decided to sell their bakery. Said, okay, it's a very tiring job. Let's sell the bakery. Let's retire. Let's enjoy the grandchildren and life. But shortly afterwards, she became more and more apprehensive, limited her daily activities, developed a major depressive disorder with rumination and avoidance. She stayed at home most of the day, missing the bakery days. when she was sharing this with me, I had the idea that the best antidepressant for her was to put her back in her bakery with children waiting for cookies to be off the oven, but I couldn't do it. So I had to figure out something else. And here we go to the second phase of clinical judgment, which is clinical reasoning. Um, what is important, clinimetrics, we call it macro analysis, but it's something I'll say probably most of the clinicians do. It's simply collecting the elements and the problematic areas. And we see here we have depression, we have agoraphobia, she doesn't get out of the house. Uh, she starts having discussion with the husband. She has nausea, which causes some anxiety, and venlafaxine is also a problem. Um, so what are the strategies that we can use? First of all, we need to set a longitudinal perspective. The DSM is cross-sectional. What's going on right now? Uh, Psychiatrists are not very familiar with staging. I should think that it was introduced a little bit more than 3 decades ago. But it's important to understand the longitudinal development of a disorder. And here we are in acute with this patient acute manifestation still. Then there is another aspect, which is building unitary concepts. Again, clinimetrics may offer the opportunity of providing a broad global rating of clinical phenomena, unitary concepts, that bring together clinical manifestations that would otherwise be scattered. Um, there are many examples. For instance, geriatrics, something that is getting more and more important is the concept of frailty. In psychiatry, I've selected 3 concepts here: allostatic load, euthymia, and behavioral toxicity. Um, Let's talk about allostatic load, which derives from the work of the great neuroscientist Bruce McEwen. And it's the presence of a current source of distress in terms of life events or chronic stress that exceed the individual coping skills. And then the stress is associated with features that involve symptomatology, impairment, in functioning, and impairment in environmental mastery. What is environmental mastery? This impairment is feeling overwhelmed by the demands of everyday life. In this systematic review, we found out that the presence of allostatic overload, whether assessed by climatic methods or biological markers, is associated with poor outcomes and health damaging lifestyle habits and poor treatment response. So it's something that is very important to find out. The concept of euthymia. Generally in psychiatry, euthymia is considered, if one is not depressed and is not manic or hypomanic, is euthymic, but of course, this is an oversimplification. And euthymia is not simply lack of mood disturbances, but it's also the fact that the person has positive affect and manifest psychological well-being, flexibility, the balance and integration of psychological forces, consistency, unifying outlook, and resistance to stress, resilience. And I've been working on a psychotherapeutic approach, which is now validated by quite a number of randomized controlled trials over the world, which is called well-being therapy. It's a particular psychotherapeutic approach because it's based on self-observation of well-being with the use of a structured diary and homework, and is geared to euthymia. Uh, and let me now describe another unitary concept, which is has to do with iatrogenic comorbidity. Uh, um, First of all, let me start from a sentence that may sound to be provocative. Current diagnostic methods in psychiatry are suited for a patient who no longer exists. For a patient who's drug-free, the DSM does not consider the effects of by and large of psychotropic drugs. But these patients have virtually disappeared. A psychiatrist is 95% of patients are already taking psychotropic drugs, unfortunately, but that's the reality. And the term iatrogenic comorbidity refers to the unfavorable modifications in the course, characteristics, and responsiveness to treatment related to previously administered therapies. And these are examples of iatrogenic factors in psychiatry, like withdrawal syndromes that do not necessarily subside, become persistent post-withdrawal disorder, persistent side effects, paradoxical effects, switching. I mean, there are a number of iatrogenic phenomena that are simply ignored by and large in psychiatric literature, but they are exceedingly common. And all these manifestations be interrelated and be subsumed under the rubric of behavioral toxicity. Uh, and it's something that is very important in using clinical judgment. We already had this Italian woman who had two consecutive trials of antidepressant drugs that cause major side effects. Another strategy is interpreting links. Um, let's go back to the macro analysis I showed before. Here we start interpreting these links. So, okay, there is a major depressive disorder which may lead to agoraphobic avoidance and to rumination. And probably it's the avoidance which leads to only a hypothesis to the problems with the husband. And then nausea, stomach burning are very likely to be due by venlafaxine. And these symptoms create health anxiety in the patient. Um, Another a fourth strategy is evaluating previous treatment responses. It's very important in the clinical judgment. And the customary clinical approach to evaluating response to treatment relies on counting episodes. Uh, Apparently, psychiatrists just have to count episodes. That's it. That fulfill specific criteria. However, if you want to use clinical judgment, you should consider the entire treatment process. And this is an example, but we'll not go into that of examining the treatment process. Then we go to the third phase, decision making. The first issue is to select therapeutic targets. What are the therapeutic targets in this case? Of course, unless you subscribe to the myth that antidepressant drugs cure depression, psychotherapy cures depression. Of course, they're very important, but in addressing aspects of the depressive illness. And we see this from the example. So, yeah, yes, this woman definitely has a major depressive disorder. And she needs antidepressant medication, probably not the one that was prescribed before, and that may bring some improvement also in agoraphobia. But we also need to address the very wide avoidance of this woman. We need to stop venlafaxine as a source of problem, as a cause of nausea and stomach burning. And we need to provide some explanation to the patient about it. Other issue is articulation of treatment. We may use these strategies all together or in a sequential modality as sequential treatment in mood disorder, first pharmacotherapy, then psychotherapy. And in this meta-analysis, which we published, Jenny Guidi and I, in 4 years ago, it's really the only strategy that is likely to yield benefits in the long term in terms of relapse and recurrence in major depressive disorder. And there have been now 17 trials using this strategy. Treatment selection is another aspect. Level care is another decision we have to make. Are we going to treat the patient ourselves, in outpatient, in inpatient? Are we going to involve other people? These are all aspects that we need to address in formulating a treatment plan. And then I use something that psychiatrists are unlikely to use, which is shared decision. Regrettably, psychiatry is probably the most paternalistic medical specialty today. And but what I'm saying the patient is this: the medication you're taking is likely to cause your nausea. There may be some problems when you discontinue the medication. She had a withdrawal reaction when sertraline was discontinued. Do you prefer a rapid switch that is likely to cause more distress for a few weeks or a gradual one? Uh, this patient answered the way most of the patients, if we share decision, do. For God's sake, get me this rubbish out of my body as soon as possible. Which I did. I substituted venlafaxine with mirtazapine. Why did I use mirtazapine? Because it has an opposite effect in terms of stomach burning and nausea compared to certainly venlafaxine at bedtime, abruptly, with no intermediate step. And she's asked to call in a week to come back in a month. Um, uh, but at that point, I'd like to share with you the approach, my actual approach with patient. This was prescription number one, drug therapy. And I warned the patient, this new medication would improve your nausea and contribute at best 50% to you getting better. You should take care of the other 50%, self-therapy. So what I do, I write a second prescription about simple things to do. I mean, it's not that we are talking about sophisticated psychotherapy. We're talking about simple things, which, however, I believe that may be helpful. She should go out every morning alone for 5, 10 minutes. She should go out every afternoon with her husband. She should report what she does in a diary. She should refrain from staying active in the house. And she should visit her grandchildren at least twice per week. See, very simple thing, but they're very important in producing an effect. After a month, her nausea has improved a great deal. Her depression, in part. Yes, sleep has improved, appetite has improved, energy, interest, but she still spends most of her days at home. So, share decision again. You're doing better, but not well. We have now two choices. Either we increase the medication dosage, or you work more on the task assigned to you. And her answer was amazing. He did put your 50%. I'm positive. I did put 10 or 20% of mine at best. It's my turn now. I should more. Let's keep the medication as is. I will follow your second prescription, which she did. And after 4 months, she has certain anxiety, occasional ruminations, occasional discussion with husband. I was able to discontinue mirtazapine and to get the patient drug-free, and the patient is well at a 6-year follow-up. Uh, as a general consideration, again, does not apply to psychiatry only, is that randomized controlled trials may show comparative efficacy of treatment for the average randomized patient. Uh, Unfortunately, I never get the average classic customary patient. I get all the rest. But not for those whose characteristics depart from standard presentations. Guidelines need to be interpreted, need to be adjusted, and clinical judgment is really the intermediate step between the general indications that derive from trials and individualized treatment plans. And the conclusion of my talk and of my book is that by using clinical judgment instead of blindly following guidelines, it's possible to practice a highly effective precision psychiatry now and not 20 years from now, waiting for advances that are still far to come. Thank you very much for your attention.
Thank you, Giovanni. Please turn on your cameras and raise your hands to ask questions while our audience prepares. I have a question for you, Giovanni, because you worked between Italy and the US, and situation in the US is a lot different, uh, even in terms of opportunity to speak to patients at length. Uh, how would you compare the two systems? And the obviously drug promotion by pharmaceutical industry happens across the ocean, but would you say that what you are recommending
Well,
would be even harder to achieve in the US or not? Or
yeah, I mean, thank you for keeping a romantic view of Italy. Unfortunately, there's not much difference in terms of the influence of pharmaceutical companies and the fact that physicians have less and less time. There is a major difference between Italy and United States. Italy, as the rest of the civilized world, has a national health system, even though, of course, there are challenges to the system now, whereas in the States there is private medicine. But you see, the tendency is to is the same all over the world, I believe. To keep the time that a physician may dedicate to the patient to as little as possible. Um, and of course, this creates a very inefficient, inhumane, and difficult, frustrating practice of medicine.
Thank you. Any other questions or comments? There were a couple important comments in the chat. So there is one from Pauline who is asking, do you think pharmacogenetics will increase the success rate of antidepressants, or experience and clinical judgment more important?
Yes, well, let me be a little bit skeptical about pharmacogenetics, simply because of my white hair. I haven't seen anything really coming up in the past decades. There may be something, but clinical judgment is far, far more important. And you see, the difference is the one which I outlined in my last slide. You can practice precision psychiatry now. You don't have to wait for something that is going to come.
Thank you. And another question, quite a long text in the chat, but it's about safe tapering for patients, and many end up with drug addictions and homeless. So how to deal with that?
Well, well, the question is very broad, but and of course this will require another talk altogether. But let me point to another issue. You see, one of the major aspects that have been censored and neglected in the medical literature is the fact that when you discontinue medications, and particularly antidepressant medication, you may have these withdrawal reactions that then have been called discontinuation syndromes for having a different approach. So if you and by the way, I see David Healy is here, and we share so many battles together, but we are still alive, I must say, and in good shape. But there is a very important point. What is the safest method for discontinuing psychotropic medication? You see, there is no answer which applies to all the situation. Discontinuing antidepressant medications, for instance, in a book which I wrote, there are at least 8 clinical situations. One you may consider abrupt, the other slow, but it depends. It depends on the clinical situation. What happens in in the literature? You only generally speaking, not all the literature, fortunately, you just consider general situations which are very vague and and help you so little when you have a specific case and you have to make decisions on that case.
Thank you, Giovanni. Sophie, did you have a question?
Hi, yes, thank you. Just in terms of ADHD, I hear everywhere, an increase of, seems a little bit trendy as well. Can you hear me okay?
Sure,
Yeah.
we
Oh,
can.
sorry. And yeah, I'm sort of very curious about how clinical judgment is applied there, because it could cover up a whole load of issues. And as per your example with the Italian lady, there was a whole load of other things at play underneath it. So again, could there be something more serious, and is there more to this ADHD than we think, or is it indeed sort of a bit trendy?
Well, of course, yes, it is trendy, but you point to a very, very important issue. Um, what matters is whether you limit your assessment to some observation, checking symptoms, uh, coming to rough diagnosis, and then prescribing the medication, which is the end of the process. Or you try, for example, in a child who presents hyperactivity, to understand what's going on in this child's life, family, and so on. If you do that, for instance, I can share with you, for reasons to be rather complicated, I also assess and treat children. And you elaborate an approach that may spare medication or associated with medication. In the most severe cases, it may increase their effectiveness. But if you treat ADHD and you do not consider the family, my idea is that this is a very incomplete treatment that is not likely to work very much and for a long time.
Thank you, Giovanni. Ala, please go ahead with your question.
Hi, sorry. Sorry, I'm cooking my dinner, Giovanni. I'm really interested in what you've been saying. And we've been doing a lot of work on the mind-body interface, in particular recently on pain. So we're just analyzing results of a trial for people who are waiting for referral for low back pain to hospital. Using something called cognitive functional therapy, which has come from Australia. So it's not CBT, but it's getting people to move. And that seems to be demonstrating effectiveness. And I think you're right, you need to get at people before they're being prescribed this heavier medication. So we're also developing a trial to look at people on a waiting list for pain and using somatic practices with those individuals. So I wonder if you can say a little bit about how you think in future some of these somatic practices might actually be embedded, even though there's pressure from the pharmaceutical industry to use drugs for pain. And then last but not least, not ADHD, but autism, we have developed a positive psychology platform, which is cost effective because it uses peers. It's facilitated, but it uses peers, people who are going through the same experiences, in that case, parents of children with autism. So, say a little bit, first of all, about the somatic, the pain-body interface and how you see that developing over the next 10 years or so. And also, whether you use peer support in your practice.
Yes, thank you for for the questions, which again would require a much more
Another book.
expanded answer than I could provide. You see, a basic point which I'd like to make is the fact that we tend to think that we have pharmacotherapy and we have psychotherapy. And it's not true uh, because there is something between, which is psychotherapeutic management. So it's the fact that, yes, you can prescribe medication, but if a good clinician is not simply prescribing medication, but is giving some advice and some suggestions. Again, psychiatry is very refractory to lifestyle medicine, but lifestyle medicine is getting more and more important in the rest of medicine. Psychotherapeutic management is something that everyone should do in considering a patient, the surrounding, and really, you see, during my medical training, I had the incredible privilege of spending part of the training in Rochester with George Engel. So he was one of my teachers. So the biopsychosocial model, it's lip service, but it can be translated into practice. So again, my idea is that there are some ingredients that come from psychotherapy. In the UK, we have you have the incredible work of Professor Isaac Marks in terms of behavioral treatment. And in my opinion, it's really one of the most important psychiatrists of the past century in this. So you can use these elements. Last thing, but I only mention, yes, there is, and of course, talking about angle, pain is is one of the favorite topics. But there is also another aspect that I had to deal in my book, which is mental pain. Another aspect that is totally ignored generally in psychiatry, but it could be quite important. So if we consider both aspects the way Engel did, actually, I think that may be very, very important insights. But the point is that it's not that either you do pharmacotherapy or psychotherapy or nothing. There is something in between, and that between is what characterizes the good clinicians.
Thank you. Thank you.
Thank you. David, please go ahead.
It's call me skeptical, but I think pain is one of the great unsolved problems. The drugs are no good. They're lousy. They're either, I mean, morphine is a lousy analgesic under most circumstances. It's never been, it's hardly been tested properly because it's existed for so long that everybody assumes it works. But it doesn't in any dose that allows you to still breathe. And cognitive therapies, I find it very hard to believe that they were. When I speak as somebody who at 89 has some periods of chronic pain, but why can't people just say, this is something we don't understand and can't do much about?
Okay, yes. In a way, you see, when we consider pain, it very much depends on the on our approach. If we just limit ourselves to the pain symptoms, and you rate the symptoms in any possible way, with scales, with all types of measurement, is one thing. But if we explore, and clinical interviewing is the only way to do that, the setting of pain. Uh, uh, that's something where we may discover some very important aspects that adequately treated may yield some improvement. We most suffer from this idea of curing disorders and diseases. Then, of course, as time goes by, as a clinician, you become more modest in your your targets. But it's really the fact that many times, aside from saying, okay, the patient's pain and also suffers from depression or from other aspects of psychiatric disorders, there's not much. And medications, yes, medications may work only in part with a number of enormous problems that are associated. So it's again going back to Engel. This is a very reductionistic approach. Our medicine today is more reductionistic than it was in the 70s, and we all think they're going to be magic bullet and brainwashed by propaganda. We may subscribe to this, but then the practice shows you that is not true.
Thank you.
Thank you, Giovanni. Unless there are any other questions at this stage, I'd like to once again thank you for coming for this very thought-provoking conversation. Once again, Giovanni's book is on Amazon. You can see the further details on our website, how to reach it. And everyone have good afternoon, and we'll see you in a couple of weeks.